Then you again repeat at 24 to 28 weeks to find out whether this is over the GDM. Okay. And then hypertension in pregnancy, because some patients may already be having essential hypertension or secondary hypertension even before pregnancy, but some of them will develop pregnancy associated hypertension, we call preeclampsia, gestation hypertension, and normally it starts after 20 weeks. Now, if you see a woman with elevated blood pressure more than 140 or 90 two consecutive occasions after 20 weeks, then you consider it as a pregnancy-induced hypertension. And if it's complicated with proteinuria, you call it preeclampsia. And normally, you need to assess all the patients at booking visit, as well as in second trimester for possible preeclampsia during the index pregnancy. And each and every clinic visit, you should monitor blood pressure, and it's very important you to stick to the proper technique of blood pressure. And people who are already diagnosed with hypertension, then you may have to consider certain medication like aspirin before 16 weeks to prevent her going into pregnancy on top of her existing blood pressure to go into pregnancy-induced gestational diabetes. Sorry, preeclampsia. And then monitoring of fetal growth and well-being is also very important. Again, at booking visit, you should be able to find out whether particular fetus is at risk of growth issues during latter part of the pregnancy. If she is high risk, now present day understanding, it's better you to consider scanning 3 to 4 weekly after 24 weeks. But if she's low risk, you can offer symphysis fundal height measurement at each antenatal clinic after 24 weeks. Normally, there's no point you to measure symphysis fundal height before 24 weeks because no intervention that will be effective. And normally you need to inquire about fetal movements after 24 weeks. And a breech presentation is one of the commonest malpresentation in pregnancy. Normally, when you feel abdomen in third trimester, you may be able to find out whether it's a cephalic or breech. If you have suspicion, then it's better you to offer a scan to find out whether it's a breech or not. If it is breech after 36 weeks, the baby can turn till 37, but if baby is in breech position after 36 weeks, then you need to discuss about the delivery options. One is to turn the baby externally, we call external cephalic version, or to offer breech vaginal delivery or elective cesarean birth. All the pros and cons you need to discuss. The unexplained vaginal bleeding after 13 weeks, it's very important because if she is negative blood group, you may have to consider anti-D. Then you need to find out whether this bleeding is due to any abruption or whether she is at risk of preterm labor. And then the amount of bleeding. Then suppose if it is placenta previa, the first time bleeding may be very minimal, but second time bleeding is going to be very heavy. And you need to find out whether she could attend to the emergency with transport facilities. All you need to ask. But if she's from far away place, if she doesn't have any proper transport facilities, it's better you to keep them in the ward than sending them home. And if placental location has not been documented, you may have to arrange a scan to find out the location of the placenta. Until such, you are not supposed to do vaginal examination. And if you're thinking of any risk of preterm labor, then you need to consider corticosteroids. And vaginal discharge is a common problem during pregnancy, but it's very common. And if it is associated with itching, soreness, unpleasant smell, pain on passing urine, then you need to find out whether that is due to an infection, and then you need to take relevant swabs for culture, and then you may have to think of sexually transmitted infections, and most common being vaginal candidiasis. You can treat with clotrimazole, econazole, like local pessaries, local tablets, or local creams. But depending upon the culture, you may have to add antibiotics if it's a bacterial infection. And nausea and vomiting is very common during early pregnancy, but most of the time, these symptoms will disappear after 16 to 20 weeks. You can offer, because sometimes it's very bothersome, can interfere with day-to-day activities. Therefore, you may have to consider antiemetic medication. At the moment, most of the antiemetics you can safely use during pregnancy. Very minimal, like domperidone, then other one, what do you call, I can't remember the generic name, Maxalone, and then the ondansetron you can use. And heartburn is also very common, and you need to give proper lifestyle and dietary changes. Even you can consider antacid, like magnesium hydroxide or ranitidine, famotidine, and what do you call, proton pump inhibitors. All you can use, those are very common. And sometimes you may get patients with pelvic girdle pain. And for that, you may have to refer to physiotherapy services for exercise and non-rigid lumbopelvic belt. Yeah, that's it for the. That's a standard antenatal care that most of the Western countries adopt. And now you can discuss what are the. This is standard. What we are missing in our present antenatal care pathway. You can talk. We'll take one by one. Now, are we talk about domestic violence when you're taking your histories?
Since social history, we would like to elicit that as well.
Yeah, because that part of our history, I think, is lacking. You need to ask whether the domestic situation with her, whether it's conducive her to be living in the same environment, whether she's going to be abused. That's all you have to ask. And then there's a history. Now, examination. Now, we know we all do height, weight, and BMI. We all do dating scan, but we don't do much proper Down syndrome assessment in our antenatal care, because reason being, we don't have trained doctors to do proper nuchal translucency, and we don't have much funds to do what you call serum biochemistry, even though that's a standard thing. And then and routinely we don't offer anomaly scan. Again, reason being, we don't have trained staff to do anomaly scan. But basic other growth and placenta localization we can do. And normal at 28 weeks anti-D prophylaxis to Rh negative mother is a known thing, and it's widely practicing in other part of the world. But still, Sri Lanka, because of the financial problem, we can't offer it to everybody. Because if you start to offer routine anti-D prophylaxis for our Rh negative women, because we don't have much stocks to give for other essential like after childbirth. If you use it for routine antiprophylaxis, you might run out for the normal delivery after for Rh negative mothers. Therefore, we actually we don't give in government hospitals. And um, yeah, again, venous thromboembolism risk assessment again is not properly happening in our setup because we are thinking that it's less common than other part of the world, but we are seeing a lot of patients with thromboembolism and maternal deaths. Therefore, concentrate on risk assessment for thromboembolism. And standard being South Asian, we all do OGD twice. There's nothing much we to change that. And then uh, again, it's very important because if risk assessment for pregnancy-induced hypertension that you need to do at booking visit, and if she is at high risk, you may even consider starting aspirin before 16 weeks. I think that is also not routinely happening, but it's very important. We can improve that one in our antenatal practice. Then now fetal growth. Now important thing at booking visit, you need to assess whether this fetus is at risk of IUGR. If so, you may offer serial ultrasound scan from 24 weeks onwards. But if she is low risk, you can measure symphysis height, but after 24 weeks. When you're working in the antenatal ward, you just see their routine antenatal record and see they have started measuring symphysis height from 12 weeks onwards. I don't know why. It's time consuming. There's nothing you can gain from measuring it because no action you can take before 24 weeks. Again, that practice we need to change. Uh, Other things are same that we ask fetal movements each and every moment. Like this. Breach presentation again, there's no much change because if you have a suspicion of breach, you always refer to a scan. And if scan confirms breach, then after 36 weeks, you offer external cephalic version, breach vaginal delivery or elective cesarean section. Bleeding after 13 weeks, again, is very straightforward. Same, nothing much we can change. We are all in line with the same guideline. Yeah. Yeah, that's now the what are the things that we need to improve to come to this level of antenatal care in our practice. Now, my second question: can we do something else to improve it further than the well accepted level? Now, main feature of our antenatal practice is that we see our pregnant women much often during latter part of the pregnancy. We used to get them weekly after 36 weeks. Earlier, before 28 weeks, we see them monthly. Between 28 weeks to 36 weeks, we get them every 2 weekly. Thereafter, weekly. Now, reason being, we see most of the pregnancy complications are common during third trimester. For example, fetal growth restriction, pregnancy-induced hypertension, gestation, diabetes. All problems are very common during latter part of the pregnancy, but not during early pregnancy. Now, at the same time, we don't have system to find out who are actually at risk for those complications. If you don't have a system to find out who are actually at risk of those complications, you tend to see everybody to pick up them during latter part of the pregnancy. It's again not cost effective. Now, in present day fetal medicine and obstetrics, we can take some biochemical test of the mother, biophysical test of the mother, and the history. You combine with the maternal history, and you can predict almost all late pregnancy complications. For example, if you consider her history, whether she has had previous preeclampsia, whether she has got any previous medical conditions like renal problems, and you measure her present mean arterial blood pressure in both hands, you get the average, and you check the blood flow to the uterus through the uterine artery from ultrasound scan and see the resistance of that blood flow. At the same time, you can measure some placental hormones, mainly placental growth factor and pregnancy associated protein 8. When you combine all together, there are few, about 6, 7 factors altogether, then you can predict up to 7 to 80% certainty whether this patient is going to get early onset pregnancy induced hypertension or not. And if this is high risk, always you can treat her with aspirin. You can give prophylactic aspirin before 16 weeks, and you can reduce that incidence by 50%. And same as for diabetes, there are certain biochemical markers like adiponectin, insulin-like growth factor. You put everything together, and then you can make risk. Another important thing, preterm labor. Now, preterm labor is the reason for us to get low birth weight babies. If they deliver prematurely, they are going to be low birth weight. To prevent preterm birth, the one intervention that you can do is you can offer cervical length assessment in all the patients at anomaly scan. If cervical length is less than 2 millimeters, that particular woman is at very high risk of going into delivery before 28 weeks. For them who are having cervical length less than 2 centimeters at anomaly scan, you can offer elective cerclage, or you can use natural vaginal progesterones, and it will prevent preterm labor up to 45 to 50%. That's the story. Likewise, you can read there are a lot of articles on this for each and every, but it's evolving. Still, there are certain biochemical markers are being tested. With time, we should be able to find out almost all the complications during early trimesters. Yeah, that's it for my lecture. If you have any questions, you can ask.
Sir, for how long is the aspirin continued if we detect a high risk pregnancy?
Yeah, up to 34 weeks. Beyond 34 weeks, no need actually giving aspirin. But important thing, the what you call expected risk reduction will come if you start aspirin before 16 weeks. No point starting aspirin after 16 weeks, that you may not get the same 50% reduction if you started after 16 weeks. The important thing now, if you are going to start aspirin for patients who are having medical concerns like renal diseases, or any other connective tissue disorder like APLS, and it might not give the same risk reduction as for other risk factors for preeclampsia. That also have to keep that in mind.
Okay, sir. Right.
Yeah. Any other question? If you don't have any other question, then we can stop. Thank you.
Thank you.
Thank you, sir.